Good morning, everyone. Before we start, I just wanted to have a few housekeeping items taken care of. We wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous peoples across Turtle Island, and we're grateful to have the opportunity to work on this land. The Temerty Center for AI Research and Education Medicine at the University of Toronto has been made possible by the generous donation of the Temerty family. T-CAIREM is an interdepartmental center that serves as a focal point for collaboration among healthcare providers, trainees, researchers, computer scientists, engineers, and industry. And our goal is to transform health through AI. So just a quick note, please use the Q&A function in Zoom to submit your questions for today's speaker, and she'll address them during the discussion portion of the webinar. And by attending the event, you're consenting to being recorded for non-commercial use by T-CAIREM. My name is Abhishek Moturu, and I'd like to welcome Dr. Mamatha Bhat. Dr. Mamatha Bhat completed her medical training at McGill University, transplant hepatology training at Mayo Clinic in Minnesota, and a PhD in medical biophysics at the University of Toronto. Dr. Bhatt's group has developed and is deploying machine learning algorithms trained on clinical and omics data to optimize the long-term outcomes of transplant patients in a personalized manner. She's received the Polanyi Prize, the Early Researcher Award from the Ministry of Research and Innovation, the CASL-CIHR Research Excellence Award, the American Society of Transplantation AST Basic Science Career Development Award, and she's a fellow of the AST. And I'll let her present today.
Hey, well, hi everyone. It's my pleasure to be presenting at today's speaker series. So I'm partnership and engagement lead for T-CAIREM, and I'd certainly encourage all of you to join us as members if you haven't already. We really enjoy having exciting discussions, as well as engaging our members in the activities of T-CAIREM. Now, in terms of my own clinical practice, clinical position, I'm a transplant hepatologist, as Abhishek mentioned. So my clinical practice is essentially assessing patients with end-stage liver disease or liver cancer for transplant. So there are different indications for transplant. And I take them through the process of evaluation. These are patients referred from all over Ontario and Manitoba, but also the rest of the country, especially for living donor liver transplantation. We are the largest transplant program in Canada, certainly, and one of the largest in North America. And so there's a lot of expertise here at the center, at Jumeirah Transplant Center. Otherwise, in terms of looking after transplant recipients, so I do also do inpatient service, and I look after patients post-transplant. So I have an outpatient practice of 350 liver transplant recipients. And, the great thing about this is whoever I evaluate and see with, liver failure prior to transplant, I then, take care of post-transplant. And it's really miraculous to see that transformation and, really, a miracle to see how well most of them do, and really gratifying for me as a clinician. So that's my clinical work. And basically that clinical work really has inspired a number of different clinical questions that then are able to be addressed with AI methods, novel AI methods. And so I really use, my clinical experience, as well as discussions with patients, patient partners, through the Canadian Donation and Transplant Research Program, to really inspire the important clinical questions in our field that could be addressed using different AI methods. And so it's very interesting to be able to do that. And so my research team is comprised of 14 members, and over half of them are computer science postdoctoral fellows. or graduate students in computer science, as well as bioinformatics and clinical fellows. And we're also fortunate to have fellows from all over the world joining also for transplant hepatology training, but then also to come and do some research training. So with all of that background, the theme of today's talk is around multi-agentic AI for objective consensus decision-making in healthcare. And really the work that I'll present to you in transplant is inspired by my experience as a transplant hepatologist. So here are my disclosures. Some of these slides were made with the help of GPT-5. These are my industrial disclosures and peer-reviewed grants, current and some in the past. So this is the outline of my talk. We'll start off going over what are AI agents and how they are being used in healthcare, and then an introduction to multi-agentic AI tools. And then we'll get into the inspiration for the multi-agentic liver transplant selection committee. So what are AI agents? So these are large language models that use artificial intelligence to perform tasks, interact with their environment, and learn from experience. And they can engage in inter-agent communication to collaborate, to share information, and make decisions collectively to solve problems. And this has been used extensively in the business world. AI agents are used for increasing efficiency, automation, as well as for process improvement initiatives. And so what is agentic AI in healthcare? So agentic AI systems perceive, reason, plan, act, and learn autonomously. And then they move beyond static LLMs. So they're dynamic tool-using agents. They can integrate large language models and sensor data, as well as structured clinical data, and enable continuous decision cycles in care workflows. So how can you consider agentic AI for decision-making in healthcare? Well, agentic AI tools can perceive the data, including collecting and interpreting the data, as mentioned here, reasoning, planning accordingly, so developing strategies and care actions, acting, so this is implementing planned care strategies, and then learning from whatever outcomes result from the intervention of the large language model or the agentic AI tool, to then refine strategies moving forward. So why does agentic AI matter in healthcare? Well, healthcare requires multi-step interdependent workflows. There's consensus decision-making, but there's also multi-step workflows and subsequent decision-making. Current AI tends to be predictive, and agentic systems are more action-oriented. And this can enable closed-loop care and adaptive treatment pathways. It can also support administrative automation and clinical decision-making. And so you can see how, the agentic AI approach can synergize for optimal outcomes with action-oriented and AI agent-driven decisions and subsequent outcomes. This is the workflow. So the input data may be unstructured clinical text, patient history, labs and imaging reports, clinical guidelines, literature. You have the large language model, plus you can augment that large language model to help it understand, what are local guidelines, so that it's aware of the context of a decision. So you can use this approach called retrieval augmented generation or other context-aware LLM methods to then better make decisions that are not going to be susceptible to hallucinations. Then you can also consider integration of multi-source info, so history and guidelines and labs. Then the output is personalized treatment recommendations, risk predictions, natural language summaries, and decision support for clinicians. So this will enable triage and next step management. What is the architecture of agentic healthcare systems? So you will have perception, which is EHR, wearable data, imaging labs, and conversations. So this is gathering data from various sources. Reasoning, so this is the large language models, graphs, Bayesian models, reinforcement learning, so reasoning. And then action is task automation, patient interventions, and decision support. And then finally, feedback. So we mentioned this in an earlier slide, but this basically provides you with an approach that can be multi-agent. So each, LLM at each step of the way then would be multi-agent, like would represent a multi-agentic kind of sequence of tasks. So what are key use cases in clinical care? You can have chart review triage, as mentioned, medication safety, imaging workflows, patient-facing use cases, including adaptive cognitive behavioral therapy, mood agents, wearable-driven interventions, and then what are systems level operation use cases, so scheduling, capacity optimization, and OR planning. So here's the anatomy of a multi-agent system. Here, this is an example from Google Research of a multi-agent system that consists of a specialist data science, health domain expert, and health coach to address diverse consumer health needs. So the data science agent decomposes an open-ended query into a structured analysis plan and will compute accurate results by coding. You then have the domain expert agent providing reliable medical knowledge, performing differential diagnostic reasoning, contextualizing and personalizing health information advice, multimodal data synthesis and reasoning, and then finally the health coach agent, which will guide and provide a goal identification, active listening, context clarification, empower the user, so user empowerment, personalized coaching recommendations, and then user feedback incorporation. So this is, the anatomy of a multi-agentic system that could be used, say, as a personal health agent. And this is from the, Google team. Okay, so now I'll move on to liver transplantation as an example. And the work that I'll show here is now accepted in Lancet Digital Health and will be published in the coming months. We have it on medRxiv as well as of December 8th, 2024. And so it took a while to get through the whole review process, so a year, which was longer certainly than we wanted it to be. But basically, it was very interesting, I think, and exciting work that was really inspired by the need for objectivity in the decisions we make. So, liver transplantation, as many of you will know, is the only definitive treatment for end-stage liver disease. And in the liver space, we have no machines that can replace the unique functions of the liver. So the liver has over 500 functions, including metabolic processes, different mitochondrial enzymes, different proteins that are produced for various aspects of human physiology. And when that liver fails, it's only then that one will realize the value of the liver. But unfortunately, by then, there's no machine to support the survival of an individual. And so liver transplantation really is a life-saving treatment for end-stage liver disease. So this is in contrast, actually, to the other organs where you can at least have a bridge to transplant. So kidney failure patients will be on dialysis, and this will keep them alive. For lung and liver, you do also have bridging modalities, but for liver, we don't. And so there is clearly a need to make decisions that are evidence-based, consistent, and objective. Now, this particular decision is made by a multidisciplinary selection committee, and the process of identifying candidates for transplant is vastly understudied and understudied and prone to inconsistencies, center-specific rules, so written or unwritten, external pressures, hidden biases potentially, and also recency bias. So, say for example, one of my surgical colleagues has had an adverse event or an adverse outcome a few weeks ago that will subconsciously influence the way that they will provide an opinion on a patient's candidacy for transplant. However, conversely, if they've had a very good outcome, or one of us has had a good outcome, then we may kind of say, okay, well, I think we should, consider this patient for transplant because the benefits outweigh the risks. So there are specific criteria for transplant. Now, that being said, there are specific criteria. There are criteria established by Trillium Gift of Life. And so you will see that on their website. There are clear criteria for candidacy, for indications for transplant. But then, the reality is that each patient comes with their own complex history. And so the reality also is that it is highly dynamic over time. So say sometimes you have patients who may not have been candidates, say just even 5 years ago, but now have become candidates by virtue of having, for example, stable cancer. So like say CML that is stable on one of those newer generation agents. Now you can say that the prognosis of this patient is good enough that perhaps the benefits of transplant outweigh the risks because they would otherwise pass away of liver failure. So the reality is that these things are highly dynamic, and then subconsciously they may be influenced by supply-demand mismatch, meaning, how many patients of ours are passing away on the wait list. Unfortunately, in Ontario, our waitlist mortality is very high, unfortunately. And so it is 25 to 30%. So that means that up to 30% of the patients we put on the wait list pass away on the wait list because they either become too sick for a transplant or they're waiting and waiting for an organ offer, and again they pass away on the wait list. So the reality is that we have to make decisions as objectively as possible, but also in an evidence-based and perhaps a dynamic way over time. And there is also, in any committee decision, the potential for the loudest voice in the room to have a significant impact on the decision either way. It can sway the decision in one way or another. So one must be very careful about this because clearly we are discussing the life of an individual, and when you make such a high stakes decision, you want it to be as objective as possible. The additional thing is we have been referred these patients by external physicians, and they will have told their patient that liver transplantation is their one definitive treatment, and if they are not offered transplant, then so basically liver transplantation is presented, and our liver transplant program subsequently is presented as their one hope. And so when we make these decisions, if we are declining a patient, it really needs to be based on very substantive and definitive recommendations and evidence. So the most objective decision possible, because it's also a matter of ensuring that the referring physicians will trust the decision that's made. And so I would say as a transplant hepatologist, we will be asked by referring physicians often, why was my patient declined? So they want to know as well, and which is reasonable. And we have to make sure that these decisions are as consistent and objective as possible. Now, that being said, the people in the room are trying to do their best and make the best decisions possible for the given patient in front of them, but there are these, potential subconscious issues that can come up in influencing that decision. So what we did actually was a proof of concept study that now, as I said, is accepted in Lancet Digital Health as of last Friday. And this was driven by a surgical resident at University of California, Irvine, so UC Irvine, close to LA. So he worked remotely with my team over a year, having approached me, and so was very enthusiastic and worked along with. Sorry, his name was Bima Hashim, and he worked very closely with Ghazal Azarfar, postdoctoral fellow in computer science, and member of our Transplant AI initiative. They worked together on driving this project to simulate the liver transplant selection committee. And we had autonomous AI agents representing different expertise to objectively select candidates based on 1 year survival outcome. And I should say, this idea was inspired by a discussion I had at a T-CAIREM symposium with Mohammed Mamdani, who's the director of T-CAIREM. So, I was asking him about AI agents, and somehow, then I thought, well, this would be very interesting to bring to the liver transplant context, because we certainly could do better. And so that conversation then, inspired this project. And my co-senior author on this is Divya Sharma, who's an assistant professor in biostatistics at York University, but was previously a postdoctoral fellow whom I'd co-supervised on some projects in the past. So basically here we simulated the liver transplant selection committee members. So we had a transplant surgeon, we had a hepatologist, a social worker, and a cardiologist. Now, this was kind of anesthesia, one can say, overall. So we had these 4 different experts review over 8,400 cases that had been generated from the Scientific Registry of Transplant Recipients. Now, the SRTR really includes cases of patients who have been waitlisted, so we did have to generate 1,400 cases with absolute contraindications to transplant. And so this was, generated, these vignettes were generated by an AI medical scribe using data from the SRTR. And then these vignettes were fed to the different AI agents. And then we asked, so there was a lot of prompt engineering involved. We ensured that each agent clearly had the expertise of a transplant hepatologist. So there was like a 2-paragraph prompt as to what the breadth of expertise of a transplant hepatologist would be: transplant surgeon, social worker, and cardiologist. And so with that lens and that expertise, we asked, say, the hepatologist to review these 8,400 cases, similarly, transplant surgeon, social worker, and cardiologist. So after each case, then the chair of the committee would ask each of these agents, okay, what is your decision? And then come up with a consensus decision. And this was all performed within OpenAI's GPT-4 LLM. And these were the sample prompts, just to give you an idea, what the transplant hepatologist prompt was. And we asked the transplant hepatologist AI agent to prognosticate the 1-year survival for the patient. And, it would be on that basis that we would identify a patient as being a candidate. So this was the workflow. Again, as I mentioned, there was a medical scribe, there was the AI selection committee that engaged in a collaborative consultation on the clinical vignette. So, prompted each committee member and asked them to break up the task and think step by step. And then each agent had their own sort of review and indications versus contraindications for transplant were identified by each of the agents. And so overall, say for this example, this patient was identified as not meeting criteria for liver transplant and needed to undergo interventions to address these issues, including, severe cardiopulmonary disease, et cetera, to be reconsidered, but clearly metastatic HCC is an absolute contraindication. So overall, the model performance, and this was untrained, it was just, using prompt engineering, was overall for the 1 year survival outcome was 92% in terms of accuracy. And using cosine similarity analysis, we were able to identify the characteristics accounting for each agent's decision, so which all were quite logical. So the social worker was interested particularly in items in the vignettes around non-compliance, insurance, social support, education, income, and any drug use or alcohol. Cardiologist on cerebrovascular disease history or history of CAD, coronary artery disease. Transplant surgeon was particularly focused on HCC. And then finally, the hepatologist was kind of, encompassing the various aspects of each of those agents as the chair of the committee. So we then looked at, how, and as I said, this is now accepted for publication, and certainly, I don't know if I had the QR code there, but certainly you can refer to our med-archived version of that paper for further information. Now, we are increasing the size of the committee to include psychiatrists and anesthesiologists beyond the initial people, as well as a transplant coordinator, who are clearly essential members of our committee, who guide the evaluation process and actually, ensure that evaluations are performed in a timely manner. And so again, the schematic overview for this next round is going to be a physician-facing agent that upon request is able to activate the agentic transplant team by assembling the relevant specialist agents and adjusting dashboards that are individualized to the clinician and the patient. So this is the agent design architecture, and then there's a committee chair. And so this is as opposed to a single agent. So really, multi-agentic really replicates what we do on the transplant selection committee. We are using PHIPAA compliant Azure architecture. And so the details are here around the use of Azure OpenAI for the next steps of our project within our UHN framework. And so we also have done evaluation of single versus multi-agent results and looked at, how the multi-agent performs in terms of both decisions as well as the rationale. So oftentimes the decision will be similar, but then, the rationale will be somewhat more elaborate for the multi-agent as opposed to the single agent. And then with RAG, we have established that the performance is improved on the UHN data. So we have been, as I mentioned, we have evaluated the performance of this model on UHN data on over 500 patients discussed at our selection committee since 2022 June, which is when EPIC was started at UHN. And by having specifically the UHN guidelines provided to GPT-4 using RAG, you can see that the decisions are much better made with RAG as opposed to without RAG. So in fact, we had I don't show this here, but without RAG, we had a performance of 65%, whereas with RAG, it was 91.6%. So we have, overall, 1,214 individuals who were assessed between July 2022 and October 2025 with the following outcomes, including list active, list on hold, declined, list with exceptions, and deferred. And these are the characteristics overall of the patient population. So you can see, 57, 63% male, BMI of 26, median MELD is 10 because many of these patients are HCC patients. So 40% of them are HCC patients. And then blood group distribution, so principally O and A. So this is the performance so far on the UHN data with our multi-agentic AI committee. 91.6% accuracy in terms of identifying those patients who were also selected as being candidates by the human committee. And so it performs quite well overall. Now we're just digging into the cases where there was discordance, and I think that'll be very interesting to better understand. We are also planning and have planned actually a multi-center international silent trial, so across different institutions worldwide, Mayo Clinic, UCSF, Vanderbilt, NUS Singapore, NUHS Singapore, National Guard Hospital in Saudi Arabia, Medanta in India. And so we have different institutions who are going to be running a silent trial over a 6-month period in order to understand how well our tool does versus the human committee. And we'll also look at fairness and objectivity, assessing the effects of age, cardiovascular health, and frailty, comparing patterns across countries to identify bias. And so these are the primary objectives, and we will, also identify, differences in terms of, the human versus AI-generated vignettes, changes in patient assessment content, concordance and textual similarity. These are the metrics that we're interested in. So the accuracy of task sequencing, detection of missing hallucinated tasks, outcome level, so AUC sensitivity, specificity for 6 and 12-month survival prediction. And then secondary objectives will include exploring clinician trust and interpretability of AI rationale, multi-agent AI committee rationale, identifying the factors that influence discordance between the AI committee and the human committee decisions. So I think all of these will be very interesting to assess across the different countries internationally, because again, we want to ensure that the multi-agentic committee is able to pull the local guidelines of the country where the multi-agent committee is going to make the decision. So, for example, in Saudi Arabia, it's going to have a RAG for Saudi guidelines versus in Singapore, similarly. So it'll be aware of the local guidelines to then generate a decision. And so we will then also be able to, so here you can see the dashboard that we've prepared. This has been prepared by our data engineer, co-supervised by Mike Brubno, who's with our Transplant AI initiative and is chief data scientist at UHN. So basically, we have a vignette, and this is the workup that we discuss every week. So on Fridays, Friday mornings, we will have a PowerPoint presentation presented by one of the transplant hepatologists or one of the transplant hepatology fellows, and it will have a summary of the workup, including the cardiac workup, so echo, stress test, CT chest, so including sometimes coronary calcium score, and then the imaging, abdominal imaging, so certainly our transplant surgeons are interested in that, and then the serologies. So all of this is reviewed by the whole committee, and basically then we come up with a consensus decision. So on this dashboard, basically we will have the multi-agentic committee come up with a decision, and then also be able to identify what were the different features that each of these agents was interested in or focused on in order to come up with their decision for this specific patient. And so I'll show the how this dashboard is going to work, and we will be running this starting in January, as I mentioned, across the different countries. So somewhat of a complicated process because each individual institution needs to have Azure available. So basically here you can see that each of the agents then is focused on certain aspects of the history, and that's what they focus on to then come up with their decision. So yeah, so overall, these are some of the next steps from our project, just to give you some insight into what we're doing as next steps after this publication. And I should also say we have a collaboration from Dr. Zach Kohane at MIT to look at, the human values across the different countries that are then potentially influencing the decisions that are made around transplantation. So overall, in summary, I think for multi-agentic AI, overall, agentic AI tools in healthcare, there's great potential to improve efficiencies in many ways, and we're starting to see this already. Prompts, in my experience with this project, prompts are critical to ensuring replication of the actual clinical context. So this is very important. And if you're working on an interesting clinical question, you absolutely must make sure that there is a clinician who will take the time, spend the time to ensure that the prompts really reflect what is ongoing in the clinical context and what is really important in the clinical context. So what is, the thought process of a physician, and especially like in our field, it's highly subspecialized. So you would require, say, involvement of a transplant hepatologist in a project like this. Like it is very important that the AI agents or the multi-agentic AI tool is clearly trying to replicate what is done in the clinical context. There's also great opportunity, I think, for greater consistency and objectivity in decision-making in healthcare. I'd like to acknowledge members of the Transplant AI Initiative and my research team. This is an older photo now, but certainly lots of very enthusiastic people and people devoted to the vision of our program, and I'd also like to acknowledge our funding sources. Happy to take questions now, and thanks for your attention.
Thank you again, Dr. Bhat, for such a great talk. I think we have some questions, so we'll just go over some of them. Vishnish Sengupta has asked, did you find any evidence of age, gender, or racial bias in the selection of candidates by AI agents?
That's a good question. We haven't looked at that. Age, gender, or you said what? Racial bias? Mm-hmm. Yeah, that's an interesting question. You see, we don't, the strange thing is that we don't have consistent data around race and ethnicity collected in our program. And this is a broader issue that has been Canada-wide, I think, in healthcare. And we are doing this more attentively now. In my program, certainly, right, we received a team grant from the CIHR a few months ago that really seeks to, improve equity and remove disparities in access to transplant and post-transplant outcomes. And certainly we want to ensure that any such disparities can be addressed in transplant care. But admittedly, we have not looked at this, and this is an excellent question. So age, gender, or racial bias. Yeah, so age, in terms of age, I would say in liver transplant medicine, when patients reach the age of 70, beyond that age, we're always very cautious because we, at least in our program's experience, have had some patients beyond the age of 70 who have had adverse outcomes and have not made it to 1 year. There have been others who are not, really biologically 72. They're really active and, are excellent candidates are being transplanted for the indication of liver cancer. So they don't have decompensated cirrhosis with the associated sarcopenia and frailty, etc. So in that case, that patient is quite different. So then, so age, certainly we think about it in terms of transplant candidacy. In Canada, we don't look at graft utility, but in some countries they do. In the United Kingdom, in some other European countries, they actually consider graft utility in the prioritization of a patient. But we don't do that in Canada or the US because we don't also want to place judgment on a person's age and preferentially offer organs to those who are younger versus older. Now, the debate there is, in some societies, they will say, well, the 30-year-old transplanted for PSC or PBC will gain 30 years of life or 40 years of life, whereas the 70-year-old may only gain 5 years of extra life because then they succumb to a cardiac event, you know? So there is that whole debate in the liver transplant community around graft utility and so on. But coming back to your question, no, we haven't looked at this, and I think it's an excellent point that we should explore for this particular project.
Thank you. Next, we have a question from Ada Zokai. How are positives and negatives defined for the accuracy calculations, particularly around survival time post-transplant? Is a negative patient survived 1 year plus, but was not recommended for transplant, or patient was recommended for transplant but did not survive beyond 1 year, or both?
Yeah, so for the accuracy calculations, it was both. So was recommended for transplant but did not survive 1 year, or patient was not recommended for transplant.
Perfect. Next, we have a question from Mol Verma. Great work. Given that your main rationale for this application is to try to improve human decision making, how are you thinking about discordance between model and human predictions? In a way, discordance would actually be good because it would speak to an opportunity to improve human community decision making. I'm sure that you've thought about this and would love to hear more about how you explore this and how you'd want to evaluate the application in a future clinical trial. What is a good outcome?
Yeah, so that's a great question. Thanks, Amol. So for the silent trial, we are basically assessing how well the tool does versus the human committee. But then beyond that, we are planning for a randomized clinical trial. Now, in that case, we are still debating whether the AI agent output would be fed to the committee to then help the human committee make the decision versus the human committee deliberates, comes up with a decision, and then the AI agent output is looked at to make the decision. We haven't yet come to a decision around this. Maybe I should ask GPT its thoughts on what would be the best way forward. Because on the one hand, I don't want the multi-agent committee then being the loudest voice in the room, right? So, kind of ironically, right, being the loudest voice in the room. So, discordance, right? So discordance, I would say, is very likely occurring when the patients are more complicated. So this does happen, and I've seen it in our experience. Like we will discuss one patient who is somewhat similar a few weeks prior and decline that patient, but then a few weeks later, maybe slightly different people are in the room. Whoever presented the case was more advocating, and then we end up listing the patient. But that's because that patient is someone with, different comorbidities, and say it was actually reasonable to decline that patient maybe a few weeks ago on the basis of, disease comorbidities. They're not likely to succeed post-transplant. But then, a few weeks later, we're not as consistent. So I suspect that those are the cases where, there's no clear yes or no, right or wrong. Maybe if we were at Mayo Clinic, like I did my fellowship at Mayo Clinic, and I can tell you they're more conservative when it comes to decisions around transplant candidacy, whereas we're a bit more kind of open to accepting more frail patients, I would say older patients, like patients who are very sick by the time they get to transplant. So there is a difference based on public versus private healthcare, on the way decisions are made, also the environmental context like waitlist mortality. In Saudi, they will be less open to ALD patients, like alcoholic liver disease patients, or in India, the program that's included is a living donor program, so they don't do deceased donor transplantation. So, like their perspectives, their values are going to be very different based on the environmental circumstances. So I think it'll be very interesting for us to actually, look at the discordance between the AI model and the human predictions, and then kind of see what might have accounted for that discordance. Actually ask the model, why is it that you think that there was this discordance with the human committee, and then have it identify those reasons, and then see how those reasons may differ across the different countries internationally.
Thank you. Next up, we have a question from Sangek Song. I may have missed this, but how did you decide the expert context or profile? Was it anchored to a criteria outside of the decision making or run multiple times? I wonder as two specialists could be quite different based on specialty.
Yeah. Expert context or profile? So you mean like the age of the expert, or like how many years of experience the expert has? That's one thing. And then whether they're female or male, or have a certain background. I mean, we didn't actually do all of that. We just told, we gave the prompt as, this is your area of expertise, and we didn't kind of assign any specific demographic characteristics. But you're right. I mean, perhaps female hepatologists are going to be a bit more sympathetic to young female PBC patients, or those who do research in a particular area, or particularly take care of those patients, are going to be a bit more wanting to advocate for other types of that specific type of patient. So it is true that there can be additional considerations, but and it's a good point. So it will be a limitation of our work, I think, that we won't be adding in certain additional factors that could influence decision making.
Thank you. Ellie Wan has asked, is 1 year survival the gold standard for evaluating transplant outcome? In the future, will more long-term outcomes be included in the consideration process?
The reason we included 1 year survival in the first proof of concept study was because we didn't have, so the SRTR only contains those patients who have been actually waitlisted for transplant. So the registry doesn't include those patients who've been discussed at committee meetings and then declined. So that was a limitation of our study, that we had to generate we had to generate cases with absolute contraindications to transplant. So we just used 1 year survival as a way to gauge, whether that decision was appropriate. Now, 1 year survival and 5 year survival are often, or anticipated 1 and 5 year survival, are often used by us subconsciously to determine candidacy for transplant. And so, it's a good point. Like, we should probably also consider including that in the prompt of our silent trial moving forward, to ensure that that also is subconsciously considered. We're not planning to include more longer term outcomes. I think perhaps 1 and 5 year survival.
We have one more question from Michael Werner. I'm a I'm an ICU physician. Do you foresee a time where AI can reliably predict if a critically ill patient should be offered artificial life support based on expected outcome?
Yeah, great question. Thanks, Michael. Well, yes, certainly. I think it will depend, though, if you have the data to train a model to do that. So this would require a large multi-center data set to look at, whether critically ill patients have had good outcomes with artificial life support, and what are the characteristics of those patients who have not had good outcome versus those who have had a positive outcome. So, I think there's a lot of critical care multi-center work going on in the GTA, and certainly a very interesting question, I think, to work on.
I think that's all the questions that we have. If there's any other questions in the last couple minutes, please feel to add them to this Q&A. But thanks again to everyone for attending this talk, and especially Dr. Bhat for sharing her insights and experiences on such a timely and important topic in the field. Um, uh, I actually have a quick question, actually.
Sure. Yeah.
Wondering, because you have the kind of the multi-agent system, I was wondering how you dealt with was things like hallucinations a problem in any of those agents, and if it was, how was it affecting the other ones?
So this is why we included RAG with our model evaluated on UHN data. So we did determine with the UHN data, when we looked at, I think it was 1,200 patients who had been discussed over the last 3 years, we determined that the model was not performing well at a rate of 65%. But as soon as we gave it the local guidelines, the Ontario Trillium Gift of Life guidelines, as well as our institutional guidelines, it then made decisions that really reflected, the the decisions that had been made by our committee. So I think it's very important for the model to understand what are the local guidelines, local considerations.
Mhm.
Yeah, but you're right. There was a concern around it giving hallucinatory decisions with that 65% accuracy.
Right. Thank you.
Yeah, so I think the way to address that is with RAG, making sure that you're giving it the local guidelines for consideration.
Mhm. That's, thank you again for such a great talk.
Yeah, my pleasure. Thanks so much, and for the invitation, and yeah, happy to discuss further if people are interested in doing similar projects in the future.
And T-CAIREM again has a large AI and medicine network in Canada, so it brings together trainees, researchers, clinicians, educators, and industry to advance healthcare through AI. So feel free to check out the directory.tcairem.ai link. And there's also an AI learning hub, learning.tcairem.ai, where we've developed a resources hub for clinicians, students, researchers, and educators looking to learn more about AI and medicine. And feel free to use these or share them with your students. TCRM's also now accepting applications for the 2026 summer research program. So it'll be 30 paid positions that are available to students across Canada. And we have a PDF up on the website on the screen with a list of hiring supervisors. So once the student finds the supervisors, they can submit a joint application by January 25th. And at 3 p.m. today, there will also be an online information session to answer any questions that you might have about the summer research program. Thanks everyone again for attending and have a good afternoon.